I would like to begin by acknowledging that the University of Manitoba is on the original lands of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. Welcome to this evening's topic for discussion, Body Donors, the Silent Health Educators. Tonight's panel is made up of University of Manitoba expertise in this field of medical education and research. Under the guidance of your moderator this evening, the team will share their knowledge on the latest research and innovations of educating healthcare professionals with body donors. You will learn about the many meaningful ways in which body donors can help to educate our students to better serve healthcare needs. I can attest to the impact body donors have on student experiences in learning, as I have 3 children who went through the medical school. This brings us to your moderator this evening. Dr. Sabine Hombach-Klonisch is a professor and department head of of human anatomy and cell science at the Max Rady College of Medicine, Rady Faculty of Health Sciences. She received her medical training and anatomy specialization in Germany and joined the University of Manitoba in 2004. Her research focuses on metastatic breast cancer and brain cancer. She enjoys teaching clinically relevant anatomy to undergraduate and graduate students and clinical trainees in different professional programs. As department head, she supports educational initiatives that convey the important relation between structure and function from the body and organ level to cell and molecular level. Dr. Hombach promotes clinical anatomy training as an essential educational resource for trainees in the health professions. She will introduce our panel for tonight. I encourage you to participate in the conversation and pose many questions to challenge our experts. They will be happy to share their knowledge. Thank you, Megwich. Merci.
Thank you very much, Dr. Jayas, for this introduction. So I'm the moderator for this evening's café, and I will give you a quick overview of how we plan to proceed with that Café Scientifique. So each of our 3 panelists, they will speak briefly on their perspective, on their experience, and with their expertise on tonight's topic for this discussion. And then I will open up the discussion for questions, and I encourage you to ask questions, to post questions, and to participate in the discussion. The questions, they can be posted via Slido. So there is a link in the YouTube description in this feed that you are watching right now, and also on the screen throughout the discussion to find the way to post your questions. So you don't need to download any software. You can just use this application in your internet browser and use the discussion code that is posted. And I'll be moderating the questions from the Slido posts, as well as the interactions with our panelists this evening. So I would now briefly introduce tonight's panelists. They are Dr. Alexa Hryniuk, Dr. Zoe Piggott, and Mr. Jakob Weirathmueller. And I'll start with Dr. Alexa Hryniuk. She is an assistant professor and an educator in the Department of Human Anatomy and Cell Science at the Max Rady College of Medicine. She completed her PhD at the University in Ottawa in molecular and cellular medicine. She did her master's at the Lakehead University in biology with a focus on medical diagnostics, and an honors BSc from the University of Western Ontario with a double major in pharmacology and medical sciences. She completed her PhD. She joined the Medical College of Georgia in Augusta, in Georgia, for 5 years, before coming to the University of Manitoba in the fall of 2019. Dr. Hryniuk's research interests have changed from originally intestinal development, homeostasis, and cancer during her PhD work, now to medical education research in her faculty position involving curricular and course design, learning outcomes in healthcare professional education, assessment interventions, and retention. So this is a very important topic. At the University of Manitoba, she directs the pre-clerkship course for women's reproductive health for the first-year medical students. I would now like to introduce Jakob Weirathmueller. Jakob is a third-year medical student at the Max Rady College of Medicine. And during the summer after his first year of medicine, where he was exposed to the anatomy laboratory, Jakob worked as a dissector for the anatomy lab at the Rady Faculty of Health Sciences. He prepared pro-sections for the various anatomy courses offered by the faculty. Preparing pro-sections means that you actually do the tedious dissection work to expose the structures that need to be demonstrated. Wanting to pass on his love of anatomy and hands-on learning, Jakob began instructing anatomy labs for the first-year medical students during his second year of medicine. And Jakob remains passionate about medical education and continues to be involved in the development of several educational tools, including surgical simulators, as well as mobile applications for physicians. Next, Dr. Zoe Piggott. She is an emergency physician at St. Boniface Hospital and an assistant professor in the Department of Emergency Medicine in Max Rady College of Medicine. She completed her medical degree at Queen's University and her emergency medicine residency in Manitoba. She also works as a transport physician, assisting in both the helicopter medevacs and longer distance patient transports from northern Manitoba. She enjoys teaching and learning from emergency medicine residents, especially toxicology and procedural anatomy. So now I would like to call the three panelists to introduce themselves, and I would like to start with Dr. Hryniuk. Alexa, please.
Hi, good evening, everyone. Thank you for joining us tonight. I am pleased to be here tonight to talk to you about the wonderful silent teachers that we have down in our anatomy lab with us as we're down there with all various healthcare students. Just here we have our memorial to help commemorate all of those people who have come through and generously given us this gift that we then get to transfer to the students as educators. In my experience in the anatomy labs and teaching of medical students and other healthcare professionals, the gift that body donors give and the lessons that they teach the students go far beyond just the anatomical pieces that put together the human body. And so from that standpoint, I really believe that they are part of our team of teachers as we help guide our medical students and our healthcare professionals through their studies. And so I just wanted to give a little sort of background about where maybe we were and where we're going in terms of how our silent teachers can help our students. This image is very classic in terms of anatomy and what we think of as medical students standing around an instructor or an educator who's going to take them through their journey in learning anatomy. And here's really what we do, or what it looks like where we are. So we have we use a combination of technologies as well as our body donors to help us teach all of our healthcare students their anatomy. And there's been a great debate in the literature over the years whether or not having a body donor for our healthcare students really helps them learn their anatomy versus could we just use a virtual form of education for these students. And but once we parse it all out, the students have a better appreciation at the end of the day for not only the anatomical structures, how it connects to the clinic, and even how it connects to people from using this in using a body donor in their education. But once you link that with the technology that we're able to use, the they're able to make all sorts of connections that they might not have before, from clinical presentation to how a procedure might have to happen. And all forms of healthcare professionals benefit from this type of study. And so one of the things that I really like about this type of teaching is that we can also interprofessional development with our students. So our healthcare professionals range from PTs, so physician assistants, physiotherapists, occupational therapists, dentists, physicians. All of these people are trained under us in their anatomical knowledge journey, and they also get to learn from each other as well as their silent teacher, the body donor. And with that, we can build up a really nice foundation of interprofessional learning amongst our students. So they're not isolated from each other, because they're going to be doing these types of interactions, having these types of interactions once they get beyond the anatomy lab. And something else that I just wanted to share with the audience as we continue on this journey tonight, the students not only learn anatomy from the silent body donors, they learn about these people, even though they've never met them. They will learn various chronic illnesses that these patients have suffered, and they get to learn about those illnesses and how they may help future patients with those. They get to learn about communication between each other. So as they're discussing findings, as they're talking about function and how this relates to clinical scenarios, the students are talking amongst themselves. They get this sense of community. They also get a sense of humanity as well, because they have this appreciation for the fact that they have this silent teacher who has selflessly donated themselves to help and further their learning. And so they get a great deal more than just the anatomy that a lot of people think that they get taught. And something that was very, very fun that I got to do recently with the fourth year medical students is we actually brought them back into the anatomy lab. So these are a group of students who are just about to graduate. They're just about to match into their residency. And so they came back for an anatomical refresher, and you can see them here. We used our body donors as well as our technology in the lab that we have here at the University of Manitoba to relate all of the structure and function to clinical scenarios, but also to radiology. So the students are seeing the human body in a 2D form, whether it's from X-ray or CT or MRI, but they're getting that refresher of anatomy. They're linking it back to their clinical education. And so it really brings their education full circle from anatomy that they had in first year, learning all the clinical scenario, and then reintroducing that back to help complete their studies. So we've had a lot of fun doing all of this, and I welcome any questions that you all have for this evening.
Thank you very much, Alexa. Now, Jakob, would you like to continue and just talk for your expertise and for your interest in this topic? Thank you, Jakob.
Yeah, absolutely. So I think that, I have a bit of a different perspective from everyone here tonight, since most of my exposure in this setting was as a student. And, I'm still right in the middle of my medical training since I'm in my third year. So it's still, my experience in the anatomy lab is still something that I'm understanding today more and more in terms of how much it's added to my medical education now that I'm interacting with patients on a daily basis. And, as Dr. Hryniuk said, it truly is this experience in the anatomy lab is an educational experience that is far beyond the anatomical parts that make up the human body. It's difficult to explain without, or I think it's difficult to fully explain the effect that it gives when you're in the room with the donors, instead of just looking at pictures in a textbook and learning your anatomy from even more advanced like electronic tools that are constantly being developed. But being able to actually see the physical thing before you, and like the arm or the leg, and being able to have that three-dimensional kind of capacity to visualize the anatomy is something that really is lost when you're just looking through pictures in a textbook or looking through visualizations on an iPad or your phone or things like that. And so I think that, you know, this word that they're, you know, the silent teacher is something that really rings true to me and has rung true to me to this day as I continue in my medical education. And one thing I remember hearing during the first few days of medical school when we were introduced to the anatomy labs is this discussion about the donors in the labs being our first patient. And that had an impact on me then, but I think that only developed more and more meaning as I progressed. You know, like it was said previously, we do learn a lot about the patients that are, or, you know, the people who have donated their bodies in front of us. And you learn about the life that they have led in terms of, you know, if they had cardiovascular events, you know, issues with their heart, or, you know, if they've had knee replacements. Like, you can see things like that, and you really feel like you're developing some kind of a connection with this person, even though you never had the honor of actually meeting them in real life while they were living. But it's truly a humbling experience from that perspective. And I think that one of the biggest things that I learned early on from that experience that certainly carries over to now is, you know, learning about really basic things that I think are important, you know, when you're giving medical care to someone, which is learning how to even, you know, interact with the body as the caretaker of that person and their medical care, like how to treat it with dignity and respect. And those were things that were definitely instilled early on in these anatomy labs. And I think that on the note of its impact on my own education, there was something really special about, you know, being in the lab with many different teachers. When I was a student, you know, from the student's perspective, there was so much I learned then that I'm realizing now is so important in my day-to-day, you know, be it in the operating room or in the clinic when I'm interacting with patients that way. Like being in the anatomy lab and then having doctors like Dr. Hombach being able to, you know, walk you through the anatomy and explain, here are things to look out for when you're treating real patients. Like here are important issues that can arise in this area. Like when a patient has a heart attack, this is what the heart can look like, and this is what is happening. And you can hold it in your hands and really learn that lesson in a very hands-on way, which to me was really important. And so I think that, you know, the time I spent in the lab in my first year, and even the time that I spent, you know, dissecting and making prosections in the summer after my first year, definitely taught a lot of skills, even in terms of like dissection skills that carry over certainly today. Now that I'm, you know, rotating through my clinical rotations and I spend time in the operating room, there's certainly things that have crossed over in a very real way. And then also just being able to identify, you know, like I said previously, just, you know, where different anatomical parts exist as parts of a whole, that really is important when you're in a setting like the operating room. And so, you know, I think that the bottom line is I can't stress how important the physical aspect of being in the anatomy lab was to my medical education. I think that there's tons of wonderful resources that exist, from textbooks to like I said, these applications that have been developed, and pretty high level ones where you can, you know, three-dimensionally manipulate things on the screen to see it from different angles. But those can only go so far. But when they're paired with the hands-on experience in the anatomy lab, it really elevates the level of medical education to another level. So, you know, I'm really looking forward to being able to talk more about this tonight, and looking forward to answering whatever questions that might come up.
Thank you very much, Jakob. And I think you touched a bit on that journey that you have taken from the first year when you entered the anatomy lab, and you explained that this is something that brings students who are in the beginning of this training just right away down to the reality. This is what we're doing this for. It is for the human beings. It is that we have and find that motivation to learn more. It's not about exams only. It is about, these people. And that is something that you said very, very importantly. And this is in the beginning, I think, as important as later on. And that, as you describe the journey, that brings me to Zoe Piggott. Please, maybe it's your turn to come from the clinical side and talk a little bit about the anatomy experience.
Thank you, Dr. Hombach. Thanks for having me today. I'm really excited about this topic, and honestly, it's been an honor and a humbling experience to be part of the procedural anatomy curriculum that we have in the emergency medicine program at the University of Manitoba. Residency, for those of you who might be a bit less familiar with the medical education system, residency is what comes after medical school. So medical school, you do a lot of studying, both practical and didactic learning. And at the end of medical school, you become a physician. And then after medical school, you pick your specialty, the kind of medicine that you want to practice on a daily basis, and spend anywhere from 2 to 5 years essentially functioning as an apprentice and learning how to care expertly for living patients in your chosen field. And for emergency medicine residents, that includes performing several emergency procedures for your patients to treat suddenly occurring life-threatening injuries or illnesses that might arise and that we see in our everyday practice. The thing about performing procedures is you can learn about them in theory from a book, but being competent at them and eventually progressing to becoming an expert in them means that you also need motor knowledge and the practical tactile feel of performing a procedure over and over again before you become really good at it. A lot of the more common ones, the straightforward ones, the less invasive ones, or the less risky ones, can actually be learned through a combination of book learning, so studying the steps and looking at pictures of anatomy, simulated plastic models or specialized training kits, and of course in real life by being an apprentice. So in medicine, we always say, see one, do one, teach one, which in reality means you watch an expert multiple times show you how to do it on a patient, and then you do dozens and dozens more with an expert teacher, at first breathing down your neck and then giving you a little bit more and a little bit more and a little bit more independence until you can practice that procedure on your own in a living patient. And then finally, you spend the rest of your career becoming an expert truly by performing and teaching to other students and trainees, hundreds more through the remaining decades of your practice. So that works for things that come up often, or that have a reasonable amount of risk, or that can be learned in that way. But what about these procedures that are rare, that hardly ever come up, maybe once in a career, maybe never for some people, or those things that are truly intimidating to perform because of the drastic or tragic nature of the situation that you're dealing with, or that are very invasive, meaning there's more risk to the patient or more risk to the medical team in performing them, or all of the above? How do you actually train for that? How do we best prepare our new physicians who are going through residency to do those things when it's not predictable, when they may come up? Of course, we study from books for those, and we rehearse them and visualize them and look at the equipment. But some things are not appropriate to perform on patients, on live patients, because of the amount of risk and the nature of the procedure involved. And we may never see them, even if they were. So our residency program and many others across the country and across the world believe that the silent teacher, so the body donor, is the best teacher for those kinds of procedures. This picture here is a shot of some of our emergency medicine residents just a couple of days ago in the lab, actually, doing one of these procedural anatomy sessions with the help of a silent teacher and with a trauma surgeon, both of whom were teaching the residents how to do rarely performed and invasive procedures. And the experience is truly irreplaceable. You might want to ask, what kind of procedures am I talking about? What kind of things do we need to learn to do? And what kind of things are best taught by a silent teacher who has selflessly donated their body, knowing that there's no risk to them anymore after the time of their death, and there's just immeasurable benefit to the trainees and to future patients from being able to do this a few times in residency on real human anatomy before you go into the world. Before we flip to the next slide, I'll just let people know that there will be a couple of cartoon images of invasive procedures that we perform, just in case someone wants to choose not to look at those images. There are no actual images of human donors or human tissue in the photo that comes next. Okay, we can flip slides here. So these are some of the things that we practice that we rarely have a chance to practice in real life because of the rarity of these procedures and the nature of them. A lateral canthotomy is a dissection of some ligaments on the side part of your eye here that would be required in an emergency when there's a buildup of pressure behind someone's eyeball, for example, blood in a trauma or a serious infection or swelling that can result in blindness very rapidly if left untreated, and that we'd be expected to know how to do in that kind of circumstance. A cricothyroidotomy basically means inserting a tube to breathe through in the front of somebody's neck when it's impossible to put in a breathing tube and get them on a ventilator in the normal way, which would be through the mouth. The need for this can arise very rapidly. It's a critical and life-saving procedure in emergency medicine. And some of the most common circumstances that would result in the need for this would be things like upper airway burns with lots of swelling or anaphylaxis, for example, which can progress really, really quickly into a completely closed off airway. The final cartoon there shows what's called an emergency thoracotomy. And this is fortunately quite a rare procedure, less so in some very large trauma centers. When a patient comes in dying or very near death from something like a stab wound or a gunshot, sometimes the only way to repair, for example, a hole in the heart or to evacuate blood from somewhere it shouldn't be is to open the chest in the emergency department. As you can imagine, these procedures carry risk for the patient. They carry risk from blood and bodily fluid exposures and injuries from scalpels and needles to the medical team. And they're stressful for everyone involved, and you want to get it right. And the only way, I think, to be best prepared to do your best and do a good job for the patient is to have had the chance to run through this with real human anatomy, to know how it feels, to know how it looks in all its complexity, and to be able to actually handle the instruments with real human remains before you'd be expected to do this on a living patient should that situation arise in your career. I can tell you, even teaching these kinds of labs every year is of benefit to me as a practicing physician. And I watch these residents learn, and I watch their confidence in these procedures just blossom, and the understanding sometimes about how it feels and what you need to do just clicks when you're in there with these silent teachers, because you can actually see what this procedure would look like and feel like on a living patient. So final slide here, just to summarize. Human body donors teach us things that no plastic model and no book could ever teach us. They teach us real anatomy, which is gloriously complex and unique to each person, and provides just way more detail, both in terms of the look of the layers of human tissue and the structures, but also the feel, which you do have to understand to do some of these procedures properly. They also teach us real nervousness, and no one wants to talk about physicians being nervous, but of course we are, especially when it matters, when there's something stressful going on. And the presence of a human body in the room reminds us of the importance and the risk of doing these procedures for a living patient. And it lets us learn how to perform with that reality, the reality that we are going to be stressed and that it does matter very much for everyone in the room. And I think of these labs as a dress rehearsal with everything possibly made to feel as real as it would as if you were in the resuscitation room in the emergency department. So it's like the difference between, reading a script at home for a play and actually standing on the stage with the lights and the music and the costumes and everything in place. The difference between that script read through and the dress rehearsal is like the difference between reading about these procedures in a book and practicing them in a human cadaver lab with a human body donor, with a silent teacher. And finally, our human body donors teach us about real community, and we're reminded every time we have the opportunity to practice these procedures that they have contributed generously to the future of medical care in their own communities. And it's not just for us, but for the patients that we may treat in the future and for future generations of teachers, medical students, and residents and practicing physicians. So with that, I'm also happy to answer any questions you might have. Thanks for this opportunity.
Thank you very much, Zoe. So with this, all the panelists have introduced themselves and they are eager to answer your questions. They are happy to answer. So please post your questions. Again, the Slido link is provided in the YouTube description in the feed. So please ask the questions. I will see them here. They will be posted for me as well in Slido, and we can take it from there. I have already one incoming question. It's asked, can I donate my organs and then also have my body donated after organ harvesting? So maybe I can pass this on to Alexa, if you would like to answer.
Sure, absolutely. So it really is a one or the other scenario that we have here in the lab, other than the fact that for body donors that we get in the lab, their eyes can be donated before as the one organ before the rest of their body can be housed in the lab and then used as a silent teacher for our students. And so typically what happens is that if we have younger donors that are organ donors, they will do that primarily as their choice of donation, so that other people can have their organs and then to benefit from an organ transplant. And what we typically get are older individuals who are donating their body to be silent teachers for all of our healthcare students that come through the lab that we have.
Thank you, Alexa. So I'm just looking. I have one other question by Chris. What is the best way to sign up and donate? So the best way is to contact the anatomy department up front. So this would be to find in the University of Manitoba website under Department of Human Anatomy and Cell Science, or you can just type in body donor program or body donation program. And that will bring you to the website and the link to the phone number you can call. And there is also an email address that you can reach us. And then the recommendation would be that you have a conversation with Jackie Armstrong or Martha Eric Castilla in the department about the process, about the forms to fill, about the pros and cons, about the process, the procedure as such. And that would be the best way to start it. I have another question from Barbara. You alluded to knowing more about the donors as people and their lifestyles. Can you elaborate on that, please? And maybe I'll give that question to Jakob, because you were talking about it as a med student, seeing the body donors and the silent teachers. And how could this be talking to you about their illnesses, their lives? Please go ahead.
Yeah, absolutely. So I think that there's multiple levels that I could answer that question, but I think the first one is probably, there's really common things that I think happen to a lot of people as they age that you'll inevitably see in many of the donors when you're performing prosections or doing dissections, like, calcifications in the arteries, from high cholesterol levels in the blood and things like that, and cardiovascular disease or damages to bones, like broken bones that have healed, or broken ligaments or tendons. You can kind of learn a lot about a person from that perspective, like as you're dissecting through someone's like you'll notice if they, I said earlier, had a knee replacement, things like that, and you'll see more common things like that, and have that experience that I've been able to bring with me, at least to my day-to-day when I'm in the clinic or in the operating room when I'm actually doing those procedures. Like if I'm giving someone a knee replacement, or I'm in the operating room fixing someone's arteries, for example, like you can kind of have that correlate and remember, oh, I remember when I was looking at this back in first year or second year, and really be able to connect that experience in a very meaningful way that I just don't think I would be able to do if I was learning from just a textbook. It's definitely important to learning, but it's not the same level. You're not able to kind of take an image from a textbook and bring it to the operating room in the same way, or bring it into the clinic in the same way. And I think that another level that it's been really meaningful for me is it's actually taught me the physical process of aging or injuries that occur to the body in a way that has made it really easy for me to then explain it to patients when I'm talking to patients, and they're curious about, like, if they've gotten a new diagnosis about something, and they want to understand it more. I mean, I can always like look up the definition of what they've been diagnosed with, or kind of like walk them through the textbook sort of answer. But I think that it's been able to make much more meaningful connections with the patients that I'm seeing in the clinic, when I'm able to kind of really call back to my memory when I saw what was going on in the living donors, and I'm able to think back, like, okay, this is actually what's happening, and I can really, I can draw them a picture maybe in a better way, or maybe explain it in a more physical way to them, that'll make more sense and allow them to have a better understanding of what's going on inside their own body. And so I think that, the notion of learning about the lives of these patients can occur on different levels that way, for sure. And you have sometimes bigger things that have happened to people in the course of their lives, like sometimes people have had parts of their lung removed, or various organs that have had to be removed or fixed in some way. And so that teaches you a lot about these people, and when you start seeing things more often, it teaches you what's more common or what's less common. And that, of course, comes in with the guidance that I was given from the instructors that were teaching and running these labs. And I think something that was even more solidified when I was lucky enough to be in the position of an instructor in my second year, and then I was able to, at that point, I'd started seeing a little bit more of patients in real life, and I obviously had gone through the course myself, and so I was able to kind of like think back to what I struggled with understanding, and what things I found helpful in real life, like seeing real patients, and being able to convey that to my colleagues was a really meaningful experience for me.
Thank you, Jakob. And maybe Alexa, would you like to comment maybe from your experience, what we learn from the people's life when we teach?
Absolutely. So from a standpoint of the body, and potentially how the aging process, similar to what Jakob said, there's a lot that we can learn about how people lived their daily lives, right? So from a knee replacement to a hip replacement, these individuals might have been very active in their lifestyle and eventually had to go through these procedures. When we see women that come through the lab who have scars across their abdomen indicating a C-section, and then once we explore them a bit more, and we find that they no longer had a uterus, and so they were mothers at one point, and then at some point they had to have their uterus taken out, and so you go along that journey with them, and I think that that's very important. Or we have body donors that have come in with tumors from various types of cancer, and we talk to the students about how that might have impacted their lives, what kind of pain they might have been, what kind of issues they may have had being mobile, or just things that they may not be able to do in their daily life that they would have been able to do before some of these things happened. So it really brings a larger picture of the human body, of the clinical condition, and then what these patients will may have experienced during their lifetime.
Zoe, anything from your point of view? Or
I'd just like to add that that seeing human anatomy each time is unique. And as clinicians in our early days, we learn about anatomy in an idealized, sort of generic way, because however anatomy is portrayed in a book or recreated in a simplistic version of a plastic model is the average or the most common variant of what can occur in the population. But with a silent teacher, that person's unique anatomy is a little bit different than everyone else's, and it reminds you each time that you see that anatomy that that they could have a completely different pattern of arteries or veins or nose shape or eye socket shape, or a completely different shape of abdomen, or a completely different location of a vessel you're trying to find, but still have functioned and had the same functional pieces of their body as everyone else. So it just reminds us that each procedure on each patient will be a completely unique experience, and that there are threads of similarities between people's anatomy, but it's the differences that make us who we are and that we have to account for when we're trying to help the particular patient in front of us.
Yeah, thank you, all of you. And I just want to mention, because it came up here in the discussion when previous surgery was done or injuries were done, that acceptance to the body donor program can only be done when the surgery is already healed and when this is an older process. So fresh injuries or fresh surgeries is difficult for the fixation process, because bodies are fixed before they then be used for teaching. There's another question by Mark. What informations are the students given about the donor? So maybe this is something that I pass on to Alexa.
Sure, absolutely. The students really get very little information about the body donor, actually. They know that they're male or they know that they're female, and really beyond that, there's not much other information given out. At times, sometimes the age of the individual may be given out if it's pertinent to something that we're seeing in the body or that we're trying to teach the students. But other than that, it's a discovery for the students, really and truly. And so they go on this journey with their silent teacher, and they don't know what they might find, and it's brings up all sorts of discussion that can happen with the students about their silent teacher and the body donor.
Yes. And so thank you. And then there's another question coming up by Jean Patterson. Hello, Jean. Has the COVID pandemic affected the body donor program, including the memorial services for the donors in June? And maybe that's something I can answer, that so far we have not had an impairment or a reduction in donated bodies. And that is a good thing in the anatomy so far. And what was affected, though, is the burial service or the funeral service that we usually do on an annual basis. It usually takes place in June at the Brookside Cemetery. And people come together, all the relatives come together, the students, the instructors, and students from different programs and different colleges, to pay their respect to the donors. And this is what we could not do, and we will not be able to do this year in June. So this was unfortunately not able to be a common event where we can get together and commonly commemorate the body donors. So this was definitely affected by the pandemic because of gatherings restrictions. An anonymous question: are there any times or reasons that a body offered to you will not be accepted? Alexa, would you like to answer, or?
Sure, absolutely. No, a lot of times in terms of bodies not being accepted, like what Sabine was saying earlier, if there's a more recent injury, or if there some different cancers we cannot accept because they will impede the fixation process, as well as various diseases that affect the liver or basically the flow of blood through the body. So the fixation process happens through the major vessels of the body, and if for some reason they are injured or won't allow us to fix the body appropriately for teaching purposes, then we unfortunately cannot take the body.
Yeah, So thank you, Alexa. And just to add to this one, if there is any kind of contagious or infectious disease, then we also cannot take the body. And this relates back maybe to the question on COVID. If someone was known to die from COVID-19, we were not able to take the bodies. But we did not have that situation. People didn't approach us when they died from COVID in this case, so or they weren't referred to us. So that is the only thing. If it is a risk to the people who then deal with the body, who then embalm the body, or to the students that learn from the body, if that is an infectious disease, then we cannot take. In other cases, it may be acute trauma, and you mentioned that also. It may also be that there is a huge degree of obesity. Then this would also be a reason not to accept the body. Any kind of non-natural death, any kind, that would also be a rejection, for example. Linda is asking the question, could you describe what happens to the body of a donor immediately following death? Is the body embalmed, frozen? And when you are finished with the body, what happens to it? So maybe I can start with this one. So what happens immediately is that the next of kin or whoever is responsible and has the legal right to the body of the deceased needs to inform the hospital staff, the physician right away. Then the body should not be embalmed in any way through the funeral services, but they need to be transported to a cold room, and you need to leave a message at the Department of Human Anatomy or call the phone number, which is 204-789-3652. You can see that number on our website, and then make arrangements and ask whether the body can be accepted. First of all, this can only be determined when death has occurred, and the circumstances under which the death has occurred can be laid out. So, and then if the body is accepted, then the University of Manitoba will arrange for transport to the university premises. The expenses that are incurred here, they will be covered by the University of Manitoba. Unless it is outside a certain radius around Winnipeg, then a cost needs to be contributed. Should the death occur outside of Winnipeg, so the transport additional costs need to be covered, and it needs to be made sure that the bodies are really cooled within first 8 hours of the death occurring. So that is very, very important. So it needs to be access to a cold room. If this is not immediately available, then Winnipeg Funeral Services or transfer services need to be called. And this is all on our website. The telephone number is provided at the website. And then they will transport the body into a cold room. So this is what happens. And then once the body is accepted at the University of Manitoba in the body donor program, then there will be a proof of death certificate handed out by Vital Statistics Agency. We will fix the bodies. So there is a certain formalin-based fixation that will take place, and then the body is preserved. And there are different ways or depth of fixation that can be used for different programs, and this really depends on what these bodies will be used for. And then the bodies will be used for teaching in different programs, different students, different depth of knowledge and understanding. And most of the bodies will be used for a combination of different student programs. Once there is no use for the body anymore and certain times have passed, then the body is cremated. And in turn, so the cremation is done at the funeral service and will be placed in a simple urn. And then the families will be contacted about 2 months in advance to arrange for either a private burial or for a burial within the University of Manitoba Burial Service. There is another question by Nicole. What is the process for someone to donate the body, and where can we refer people looking for information on this process? So this is where the website of the University of Manitoba Body Donation Program was just highlighted here, and it is also in the chat. So this is something where you can look up body donation program, University of Manitoba, or just University of Manitoba, human anatomy and cell science. And there's all the contacts listed on the body donation program. So please contact, if you are interested, the telephone numbers at the Department of Human Anatomy, or take the email. Someone is asking, Mark is asking, how long is the body used for medical education and what happens to it? The question just went because I think it was redundant. Okay, there is the link. So you should be able to see the link to the University of Manitoba, Faculty of Health Sciences, Medicine, and the Anatomy and Service After Death. Okay, so I've lost the other questions that were posted. I have one other question here that is, why does the human body still provide a good learning resource in times of computer-based learning tools and 3D anatomy models that there are? And I think we have partially covered that, and I think we have already talked about it, but maybe Jakob, you can just briefly say, there's the human body, there is a 3D simulation. So you have gone through a couple of radiological, CT, MRI, 3D reconstructions during your medical studies. So what is the difference and why is it important still to go to a human body and learn from a human body that is a real human body?
Yeah, for sure. And I think that, this is, like you said, briefly talked about before, but I think one big thing about that I think Dr. Piggott mentioned earlier is there's the perfect anatomy that is shown in textbooks, and beyond being kind of the ideal or average, whatever you might call it, it's also often stylized. Like you might have different muscles that are colored or grouped in ways that make it visually easier to digest and easier to kind of memorize groups of organs or function, things like that. But in real life, things aren't colored for you, and it's not organized and it's not cleaned up of all of the connective tissue. So it's a lot more. If I were to just take the idealized anatomy or the average anatomy that's found in textbooks and bring that into my clinical experience now in my clinical education, be that in the clinic itself or like I said earlier in the operating room, I think I would find it difficult to really grasp what's going on. I think there would be quite a bit more of a barrier to really understanding the anatomy in a functional way or in a clinically relevant way. Because in my head, I might have, well, here are the muscles of your leg, but in my head, like your hip flexors are all colored red and your hip extensors are all green. But of course, it's not how it is in real life. But being able to actually have that hands-on experience in the lab shows you the real relationships between things and the ways that things can look different between individuals, like was mentioned earlier. And I think that is something that is really, really important. I mean, it's not to say that it isn't important to learn from textbooks as well and use these other tools that have been developed, because I continuously access those materials and use them to supplement my medical education. But I think that to lose one of those would be a huge handicap on the entire medical education.
You mentioned medical education, Jakob, and maybe Alexa, you can talk a little bit, because from your experience with medical education aspects of anatomy learning or anatomy training, how do you incorporate the silent educators or silent teachers in your concept of educational research?
Absolutely. Well, first, I'll just maybe talk a little bit about some of the educational research that has been done around whether or not we could stop using body donors in the medical curriculum or in healthcare professional curriculum. And that has been a really big debate as technologies have become more and more available. And what what all of these different studies really end up showing is that, yes, you for a very specific like learning purpose, so from the learning of what the anatomy is and what the different parts of the human body are, you could use other supplements. You could use the textbook, you could use any online resources. But when it comes to putting that together for the students, and when it comes to the real life application in the clinic, nothing can replace the body donor itself for being the first patient that these students have. But what has also come out of the research of medical education is that there is this enhancement of the educational experience and of the learning of the student when they use both their first patient and their silent teacher of their body donor, along with the educational tools, the radiological tools that we have to teach the students, the 3D images that we have to teach the students, and any of our simulations as well, because you can do the simulation to get the muscle memory down, as I'm sure Zoe can talk about a little bit as well. But the texture and the feel and the confidence of doing these procedures with a silent donor increases with our students. So same thing, when you look at the educational studies that have been done on confidence, the students who have used a body donor to as part of their education, their confidence in their clinical skills and in procedural training is significantly higher than those that don't, or that just use a simulation.
I would agree with that, Alexa. I mean, I'm truly amazed these days at the high level of simulation equipment that is available and continues to get better year by year, and at the high degree fidelity sometimes with certain task models, which are made of plastic or silicone for certain more simple procedures. But at the end of the day, when you're doing something more invasive and more complex that requires a knowledge of how multiple layers of the human body feel, multiple types of tissue, there is no plastic or silicone model that feels the same when you're doing the procedure to it as human tissue feels. And there are some very skilled ways of embalming the human body donors so that the feel of the tissue after death is actually very similar to a live patient, except in temperature, of course. And that's irreplaceable because procedures rely a lot on motor memory and on your confidence that the feel of where your needle is or your scalpel is, or whether you've gone through the plane of tissue that you need to go through is real and is where you're supposed to be. And there's no task trainer or simulation mannequin that can replace that. The other thing is there's, as I alluded to before, there's an amount of fear and an amount of respect that comes from having actual human remains in the room that also can't be recreated. Our students have the same stress response when they perform a procedure on a cadaver to a certain degree as they do when they perform it on a live patient. It's more with a live patient because the stakes are obviously a lot higher, but our residents know that this is a human body in the room, and that's different than knowing that you're working with a plastic model or that you're looking at a computer screen. And that can't be replaced, and it helps to rehearse that, to be prepared for that human response that you have when you're in the room with a live patient.
Thank you. Yeah, that's very important, I think. And I have to maybe just to give you a perspective, we had a very old anatomy laboratory a couple of years ago, and we had to make a decision basically whether we want to continue the cadaveric program and the body donation program and want to keep that at the University of Manitoba, or whether we get rid of all the body donation program. We completely switch to computer-based, three-dimensional anatomy training. And so at the time, we reached out to different other hospitals, to colleagues in other provinces. We reached out to clinical colleagues who do procedural training, and Zoe was one of them. People in Dalhousie University were others. And from their experience, and a lot of other feedback was from the clinical side, from the medical dental side, no, we want to have the body donors as our teachers. So we need to have the anatomy laboratory, because this is of huge value to us as clinical practitioners, as surgeons, from different disciplines in medicine, dentistry, rehabilitation. So this was an important feedback for us. So that led to the huge effort by the College of Medicine, University of Manitoba, to have that laboratory renovated. And you've seen some of those pictures. This is our new Dr. George Yee Laboratory of Anatomical Sciences. And it is a great place. It is very inviting. It is has a good lighting, good ventilation, and has surgical lights, equipped with camera, and still has up-to-date screens and audiovisual equipment. So this is what we have decided to do, and this is what helps many, many programs at the University of Manitoba here at the Rady Faculty of Health Sciences and beyond. So there was another question: if I donate my body, can I specifically request the program or educational activity it will go to? Alexa, you would like to take that question? Yeah.
Absolutely. Yes. So no, we actually do not. We do not prescribe who goes into what program when we have the body donations. At times, it is sometimes determined that a donor, based on maybe some of the features that we can see, might be more appropriate for a fourth-year medical training course, or for the dental school, or for rehab science, depending on what we may or may not know about the donor that has come in. But really and truly, most of the donors that come in service all the different colleges that come and train under us. And so the donors will be seen by the medical students, by the dental students, physician's assistants, physiotherapists, occupational therapists, pharmacists. The list goes on. And so all of these different medical professionals can get trained by a single body donor, from the standpoint that that single body donor has an impact on hundreds and hundreds of students in their time with us. And I think that is more beneficial than just being pigeonholed into one faculty or another to teach.
So most, and you mentioned that, Alexa, most body donors are being utilized for different programs, and different students learn from there. In rare occasions, we may have a dedicated program that we utilize a specific donor for, and this may be depending on the time constraints, because we have different fixations, and not all the fixations are preparing in the same way for certain learning types. And when Dr. Piggott was saying, and Zoe was talking about the procedural training, then this needs to be decided beforehand. So when they recommend, when they book the lab and say, this is when our training sessions take place, so we need to respect that for the incoming bodies at that time. And so not everyone is really serving all the programs, so that may be decided on the particular time point. Another question, I think, was just answered: what groups of healthcare professionals do you educate? And I think Alexa has alluded to this already. So very different groups of learners. And the next question that I have here is the UM program a mix of learning and research? And something to maybe for Alexa to answer, as you do as educational research. Zoe, maybe think about, I don't know whether you have research in mind in terms of procedural research. Maybe start with Alexa.
Sure, absolutely. So my interest area, or my research area, is not necessarily anatomical research, but it is learning amongst our healthcare professionals. So how best do they learn? With COVID, we've had to change up how we do labs for our various healthcare professional colleges. And so one of the ways that we did that this fall is to have some virtual labs with some of our classes, because they're just too big. We couldn't get them into the lab and be safe and socially distance appropriately for them. And so I did some research on whether or not an online lab using our body donors could help our students, and some preliminary data coming out of that says that yes, it does. They do still learn. our silent teachers can help in a virtual way for those students. But when the students were polled about whether or not they would like this to continue in a virtual form using our body donors, or whether they wanted to return to the anatomy lab to have the hands-on application of the anatomy, it was almost unanimous that the students wanted to be back in the lab. So even, again, I think it goes back to showing that the students really value the being in the lab, and we can do research in terms of how they learn, what procedures they could potentially get better hands-on training for. And I'm sure, Zoe, you can maybe talk about that a bit as well.
That doesn't surprise me at all, and I'm very sure if our residents were polled, their reaction would be exactly the same. The research that makes the most sense for us, given the clinical nature of what we do, is educational research, basically trying to quantify the improvements that can be made in terms of confidence and competence at these rarely performed invasive procedures. There's starting to be more and more medical education literature looking at the value of simulation for high stress scenarios that are not procedural, and the value of that, and we can apply those types of research models to these kinds of anatomy labs as well. And we've actually already had some discussions with anatomy faculty about partnering to do some educational research and trying to quantify what gains our residents are actually making objectively when they go through these labs and practice these procedures. And that has implications for not only for exam performance for them, but of course the more real life readiness to perform these things.
Thank you. And there is also, from some faculty, there is another type of research where, from a musculoskeletal aspect, the certain joints are being viewed, ligaments of the joints are being looked at. So this is a type of research that also takes place where, for example, in the knee joint, the cruciate ligaments are being looked at in a cadaveric specimen, and positioning of the different components of the cruciate ligaments or different components of other musculoskeletal ligaments are being looked at in relation to injuries that have taken place, or just to assess the movements of those different ligaments in relation to the joint movements. So this is also something that can be done in the anatomy lab. There is another question. Do all student groups participate in the same types of lab courses? Jakob, you've had some of those courses and you have taught yourself, but this was a certain subset of students, correct?
Yeah, that's correct. So, I mean, I guess I had a little bit of a more varied experience because of my pro section work that I continued during my second year. But yeah, like I obviously was in the medical class who were learning, and then when I was instructing the new first year medical students. So I kind of had that perspective. But during the summer, when I was preparing the pro sections, it certainly wasn't just for the medical students, and the pro sections that continued on during the academic year that I was doing were also for other programs. So we would prepare pro sections that were specifically geared towards dentistry students, or the physical therapy students, things like that, and specific courses even that they were taking at the time, be it like if it was women's health or musculoskeletal or cardiovascular pro sections and dissections, like so there was definitely a varied experience that way. And I got the ability to, appreciate sort of what different people's perspectives were. And because, as I was preparing these pro sections, it was kind of always targeted, and you'd get a list of things that needed to be prepared. And, you could even sometimes see the questions that students were being asked. And so you could see the different lenses through which various programs and faculties viewed human anatomy, and the different things that were emphasized for different programs based on where the ultimate endpoint was for them.
Anyone else who would like to comment?
Yeah, just I remember the differences in what I learned. back when I was a first year medical student compared to what I do now. And of course, I'm still learning through these programs. And I think what you learn depends on where you are, as Jakob was alluding to. And when I was a first year medical student, I really just needed to see in real life where things were and how they related to each other, and be able to look at the tissue layers one at a time and understand in a 3D way with the help of my hands and touching it, what the relationships were. And then as I moved along, you start thinking about physiology a little bit more on the totality of a body system rather than just what is in this part of the arm. And now as an emergency physician, teaching emergency residents, we want to know how to best do the tasks that are presented to us in our daily life. And so we're much more procedure or task focused with our anatomy, and the performance, the smooth, safe performance of those things is a different goal than understanding how the arteries and nerves relate to each other and where they lie, which is what I was trying to learn in first year medical school. It's all important, but the relative importance of those things changes as you go through your training, and having the opportunity to continue to do all of it and to change how you look at the human body over decades is invaluable. And some of those pro sections at Queen's in medical school, I'm sure had been in the lab for decades. Those silent teachers have been teaching literally generations of medical students about the relationship between body parts. And now some of the silent teachers that we have are in the lab for a few months to help us learn very quickly and efficiently how to do certain procedures. And then they're gone. But the contribution is equal. It's a different contribution depending on what the learners need. So the continued existence of these programs to me is invaluable. They're really irreplaceable.
Thank you. How many bodies are donated to the University of Manitoba each year? So maybe that's something I can answer. It is about roughly 30 to 35 every year. And I can say that for sure there is a need to increase the body intake, because more and more we are contacted in the department from clinical colleagues that there is a need to do procedural training, to bring clinicians and residents back into the anatomy lab. And so the demand is higher now than it was before. And we would definitely like to see these numbers increase rather than decrease, because the need is greater than it was before. From each panelist, is a question: can you tell us the most exciting discovery or things you learned from a donated body? Just from your memory, what was the most excited one? I don't know who would like to go ahead. It's up to you. Maybe I can also start. I mean, I remember maybe when I was a med student, I have to say, I still vividly remember this, because it is somehow the first week in the anatomy lab, and it is your very first experience in med school. You are not really prepared for that. You don't really know what you have agreed to do. So I think this was really something where it takes a lot of courage, I think, and it takes a lot of persistence. It takes a lot of you need to take the anxiety away to really examine a body, to really take a knife and cut into the skin of an arm to remove the skin, to see what muscles are underneath, what nerves are there, and what are the blood vessels, and what is the deeper layer, and what is the superficial layer. And so I found this one was exciting for me, because as a student, having never seen a dead body before, that was strange to me. So this is also a very, very important experience, I find, as a student in the health professions, because it wakes you up and it makes you realize, it is not only about techniques and knowledge and medication, but it is actually about understanding the anatomy and about seeing those people and about realizing that you will be dealing for the rest of your life with other people to help them. And so this was very exciting. And then the other exciting experience that I had as a teacher was when we just discussed around a body, and we wanted to do the normal anatomy And then we found anomalies. So we found a situs inversus, where the liver is not on the right side, but it's on the left side, yeah? And the heart is the opposite way. And then you think about, oh my goodness, everything looks different, yeah? What would that have looked like in the ultrasound? What would this person would have felt? Would he or she realize that at all? And so there is a good discussion with the students and with everyone around it. What could have been the symptoms? Why could that be not discovered? And was everything functional? And then you start, while you work with this patient, you know, you look at everything and you say, yes, everything is functional. And look, the patient is probably very, very old and maybe has not even known this unless an ultrasound was done and it was explained to him. And it's also something where I think of emergency medicine procedures now, and I'm thinking, you know, it could just be the opposite way. And so just to realize that by looking at it, by going through it, by doing an educational session, and these are very valuable discussions, I found. That's my pitch on this, but you've probably had different experience.
Yeah. I mean, if I'll jump in, I am always, I guess, maybe excited or amazed every time. I love the thorax and the abdomen and the pelvis. I like all that anatomy. I'm very, very fond of it. And I think I'm really fond of it is because every donor is different in that scenario. You never know how the anatomy is going to look when you go into the thorax or the abdominal cavity, and you never know what kind of surgeries that the patient, the body donor may have had before that. So to go in and find that they're missing a gallbladder, for example, and then having that discussion with the students about why this might be and what could have caused it. I remember another donor for helping to teach the students. So we opened up and we were getting ready to look at the normal anatomy of the intestines. And all of a sudden my one student went, wait, that's not where it should be. That's not connected where it should be. And then we had a discussion about how this person had pancreatic cancer and had to have part of their bowel removed, and then how that surgery might have taken place so that they could then have normal bowel function again. And it's fantastic at those conversations, having them with students and getting them to relate all of these things. And because we don't know anything about the body donor when we start this exploration with the students, it's always a discovery. It's not that I necessarily have one picture in my head about that was the most fantastic thing we ever discovered about a body, but it's this constantly being amazed at our body donors and how much they can contribute to our discussions. It's fantastic.
I'll jump in with mine. The moment that particularly stands out to me is actually not that many years ago. I was already a practicing physician, and I'd gone to Dalhousie actually to learn from some of our truly excellent colleagues there who are doing a lot of work with silent donors and procedural anatomy there. And I was taking part in a procedural anatomy lab as a learner, and they were demonstrating the extent of what they were teaching their own residents and the things they could do. And it was a room full of my colleagues, and they asked for a volunteer to do the cricothyroidotomy, which is that airway you put in through the front of the neck, which is a high stress, rare procedure for us. And I volunteered to do it. And I went to the side of the silent teacher, and I remember thinking very clearly how very lifelike the tissue looked, and how real it felt. My heart rate went up by 20 or 25, and I thought, oh boy, this is it. And it really felt like it was it. Because that procedure is rare enough that I'd never done one on a live patient, despite multiple rehearsals on pig tracheas and plastic models, and visualizing and pointing my scalpels around in the air with my eyes closed, things like that you do to try to prepare yourself. This was another level of preparation. And I touched the neck, and I was surprised that it was cold, because it was so lifelike. Otherwise, the room was so lifelike, and the look of the tissue of this silent donor was so lifelike. And I did the procedure, and then I thought, oh, that's what it actually feels like. And yes, I can do this on actual tissue in a room full of people who matter to me and a patient who matters to me. And it was such a valuable experience. And from that moment, I thought, this is how I want to teach residents anatomy. This matters.
I think that for me, it was kind of a collection of experiences very early on in my in my time in the anatomy lab that it's hard to pick one exact specific moment, but I remember just getting this appreciation and kind of a surprise of how both at the same time the human body is so, it's this wonderful combination of resilient and fragile. You're working with tissue, and there's you're trying to dissect like nerves apart or blood vessels apart, and you realize how gentle you have to be with certain structures, and how the smallest misplaced hand movement could cut through something that you weren't intending to cut through. And at the same time, you're dealing with skin and bones and muscle, and you're working around them. And I just remember just feeling in awe of there's all at the same time, there's structures that are so delicate right next to structures that are just unbelievably strong and rigid and sturdy that support the the person that these belonged to. And I think that really also struck a point for me when we were doing neuroanatomy, and you put your hands on a brain for the first time. It's a really incredible moment, because I think that there's a first, for me anyway, there was the first few seconds of I almost didn't really realize what was in my hands and what I was looking at, and then it kind of sinks in that this is the cradle of someone's soul. Like this was a person here. This is what took in all the information, all the happy and sad experiences of that person's life, and made them who they are in many ways. And I think that it was so humbling, just it really struck home, how humbling the whole experience of these people allowing us to work with their bodies is. This was them. This was, who they were. This was all of the summation of their life experiences in this one thing. And it's such a fragile thing. Like the smallest damage to it can cause, unbelievable changes to someone's personality or function. But at the same time, it's so good at what it does, and it allows us to do the incredible things that humans have been able to accomplish. And so, yeah, I think that it's just this juxtaposition of fragility and strength that exists in the human body that really resonated with me, and at the time anyway. And then I was really able to bring forward and develop that idea when I was working with real patients, being sensitive to that idea, sensitive to, when you're performing procedures on someone, on a real patient, you have to be really careful around certain things. And then other things, you have to put a little bit more strength into it to be able to do what you need to do. And being able to understand the difference between those two things. And, I'm obviously not anywhere near an expert on that, but it's something that I'm still really developing appreciation for, and something that is just another level to which there's nothing else I think that could have replaced that education I got in the anatomy lab early on.
Thank you. There is one question that is regarding some terminology. Prosections has been mentioned. How does that differ from dissection? Maybe Alexa, you can explain this.
Absolutely. So when we have a body donor that has donated their body, we have a team of educators and students that help us to dissect the body. So when we're dissecting, this is the actual physical removal of skin tissue and adipose tissue and connective tissue, so that we can fully appreciate and see the structures that we want the students to see that for that. And so some of our students get to participate in that dissection process. So they really get to feel the skin and understand all the layers of the body. And then when we get to using prosections, so we may not have as much time with a student group. And so we already have sections of a body already ready for them to see, so that they don't have to uncover the anatomy. The anatomy is already uncovered for them to be able to explore and to learn the variations, and they will still understand the depth, but maybe not directly from the outside all the way in. And so it just depends on the learner situation, what type of scenario we would use. But so the dissecting is actually the act of taking off layers of the body and discovering what is underneath, and then prosection is already there prepared for them, and they would just be able to see like a uterus and a bladder and fallopian tubes and an ovary already without any other tissue on top of them.
Thank you, Alexa. And maybe a little bit also added to this, that some students are really needing to experience the discovery because you have fascias in the body, and fascias keep things together. And these fascias usually need to be removed when you want to display the position of the nerves and the arteries. But sometimes for certain surgeons and other disciplines, it's important to understand where these fascias are, because these are borders to expansions of fluid, to infectious spread, and these kind of things. And so it is kind of a different experience that you have when you actually see it and discover it yourself versus when you see everything already laid out and cleaned. So that is once that, as you explained, prosection and dissection when you do it yourself in preparing this. So we're coming almost to the end of our Café Scientifique, and maybe I can ask all of you panelists whether you would like to say anything that you haven't had a chance to say, anything that wasn't a question but you feel like it's worth mentioning in this to the audience.
I mean, for me, like, it's been said before, but I think that one thing that I would just really want to drive home, I think, is like in regards to this conversation that I think has gone on at other medical schools across the country or even across the world about, whether or not the actual presence of anatomy labs is beneficial to education and the idea of removing it. But I think that I can't emphasize enough, like even this early on in my medical education, how important it has been for me, and how I can't really imagine what my clinical experiences would have been like if I hadn't had these really formative times spent in that lab early on. And I think that if going forward, future doctors don't have that opportunity, I think they'd be really missing out on something quite special and important to their education.
Thank you, Jakob. Okay, then I think we will wrap it up. I would like to thank all the panelists for being here tonight and for talking about your experience and with your expertise that you have to that topic. I'd like to thank all the audience for being there and posting their questions. And I encourage you to tune in again on May 12th for the next Café Scientifique. And this is entitled Combating Multiple Sclerosis from Different Angles. And the details on this and additional cafés can be found on the umanitoba.ca Café Scientifique website, as well as on the link to tonight's video. So I'd like to thank you all, panelists and audience, and I would like to close this café. Thank you very much. Have a nice evening.
Thank you.
Thank you.
Thank you.